Hello, everybody. Thank you for joining us today in this webinar from the European School of Urology on evolving interventional therapy for bladder outlet obstruction in men. I want to send you my best regards in these difficult times where COVID is changing our lives. So let's start with the presentation. I have no current conflicts of interest. I'm going to cover the topic in about 40 minutes of presentation, and then we will have 20 minutes for answering questions that can be asked through the question portal. I will discuss established and investigative options of treatment of BPH, lasers, the prostatic Urolift, intraprostatic injections, and other options under investigation. And I will, of course, base my presentation on the guidelines. I'd like to start by reflecting on the concept of gold standard. Many times in my life, when I have been teaching and mentoring, many people have told me, I do TURP and I am not going to change because it's the gold standard. And I think it's a failed idea. It's the current standard that we should be using. I think the gold standard concept discourages innovation. And I think we have to look at the clinical evidence, and we have to think and question our standards once and again. And I'm going to try to demonstrate the amount of evidence we have today to support that TURP is no longer the current, let's say, standard. Okay, so when I finished my residency, I could live with this mental scheme. All right, if the prostate was small, we would do TURP. If the prostate was big, we would do open. Big and small were relative terms, and maybe different departments or different countries used a different threshold. High-risk patients were condemned to long-term catheterization. Today, the situation has changed significantly, and we not only look at prostate volume, but also the health of the patient, if he's anticoagulated or high risk, if he can have surgery. And also, we are paying a lot of attention to the desire of the patient to preserve ejaculation. The main strategies for the treatment of BPH are removing the adenoma, which can be done partially, like with resection, vaporization, or ablation, or totally in an anatomic way, which is achieved by different techniques. Also, we can do things that do not remove tissue, like using the Urolift to open the channel or expand the channel. You can induce necrosis in the tissue or incise the bladder neck and reshape the form of the bladder neck to improve micturition. Let's start with lasers and the concept of anatomic endoscopic enucleation of the prostate. The thing is, when you remove endoscopically the whole adenoma, we are getting very similar results irrespective of the source of energy used. And this was a concept introduced by Thomas Herman, and I think it was brilliant because really having experienced different sources of energy to do this operation, the outcomes are quite similar. It is an operation that provides very good long-term results with minimal morbidity, almost size independent, and the energy we use is a matter of choice. As you know, lasers are sources of light. This is a monochromatic light with one single wavelength, and the wavelength is going to have different affinity for different chromophores, hemoglobin and water, and this is going to condition the penetration depth of these lasers into the tissue and the tissue effect, which changes from one laser to another. Typically, diode lasers, especially 980, has a high penetration, as the similar neodymium YAG laser did in the past. Thulium and Holmium penetrate very little, and GreenLight penetrates a little bit deeper, which explains the good hemostasis. Let's start talking about Holmium. With Holmium, you can do vaporization, although it's not very efficient. You can do resection, but this has been largely abandoned, and you can do HOLEP. And the wonderful aspect of Holmium is that it has a very high affinity for water, and it's a pulsed laser, which means that when you hit the water with the heat, with the energy is absorbed, and it produces a very fast vaporization of the water that is explosive, which generates a shockwave that helps dissect the plane between anoma and capsule. And this is unique for the Holmium laser. This explosive effect is also used to break stones, and that's why we use Holmium for stones. These are the recommendations of the guidelines, and you can see that nowadays it's not only for large prostates, it's an alternative to TURP in prostates from 30 to 80 and larger, and not only for large glands. And the quality of the evidence supporting this is very good. There are many meta-analyses published of HOLEP versus TURP and studies, and you can see that the symptom improvement is superior with HOLEP than with TURP with up to 7 years of follow-up. When you compare it to open as well, the results are equivalent, but of course the morbidity and the risk are much, much lower. It has a very low reoperation rate. There are reports up to 18 years with very less than 1% reoperation rate. And this means it's, for the majority of patients, a definitive treatment. When you look at the safety versus TURP, there's no significant differences in urethral stricture, stress urinary incontinence, and reoperation. Also, when you compare it to open in terms of safety, there's less blood loss, less transfusion, less hospitalization, and less catheterization time. It's a safe technique in anticoagulated patients, and there are a number of studies showing that it can be safely used in high-risk patients, and the effect on erectile function is comparable between HOLEP and TURP, so it doesn't affect erectile function significantly. What it does affect is ejaculation. Most patients submitted to an endoscopic enucleation of the prostate are going to have retrograde ejaculation and changes in the orgasm perception. But there's a growing interest in these techniques of ejaculation preservation. And in this paper, they could show that 46% of patients could be submitted to an enucleative procedure, but by respecting the ejaculatory apparatus, the vero and the paracollicular tissue and the ejaculatory ducts, they could still ejaculate antegrately. There have been interesting advances in technology with Holmium, and one of them is the Moses pulse modulation. It has been used for stones, but it's proving to be very good for endoscopic enucleation of the prostate with Holmium because it enhances cutting and it enhances coagulation. When I was using Thulium, I said this is the best cutting laser there is. And when I was using GreenLight, I was thinking this is the best hemostasis. And Holmium was not cutting as well as Thulium and not coagulating as well as GreenLight. But now with Moses, it has improved in these two aspects, and I really love it for the large glands because it provides very good hemostasis. There have also been advances in surgical technique, aiming especially to reduce the incidence of early postoperative stress incontinence, which was recoverable, and also to ease up the learning curve, because these have been two of the main problems with HOLEP. And these are the en bloc procedures and the early apical release. And I would like to refer you to these two papers that make a reflection of this new tendency to do en bloc procedures and to release the apex at the beginning of the operation when to prevent postoperative incontinence. Let's talk now about GreenLight laser. GreenLight is probably the best hemostatic laser. It's very safe for patients receiving antiplatelet or anticoagulant therapy, and the guidelines recommend it for patients with prostates between 30 and 80 milliliters and patients with prostates smaller than 80 that are anticoagulated. So there's been an evolution in the technology. We had 3 generations of lasers. GreenLight lasers, and the last one was released in 2009. There hasn't been any new development since then, the 180 watt GreenLight laser. There have been several randomized clinical trials, but the longest follow-up in comparison to TURP was 36 months, and the results were similar, but the reoperation rate was significantly higher after GreenLight. You have to understand that there have always been surgeons who do a good TURP and a bad TURP. Both are TURPs, but one removes more tissue than the other. So all these studies have to be interpreted in this, knowing this. The Goliath study is probably the biggest study comparing TURP with GreenLight PVP with the 180 watt laser. And it showed that a PVP is non-inferior to TURP in terms of efficacy. Also, two studies looked at the urodynamic effect of PVP, and it's indistinguishable from that obtained with TURP. So patients are equally deobstructed. In terms of tolerability and safety, also the complications were comparable. Regarding anticoagulation, most case series show that the GreenLight is very safe in patients undergoing anticoagulation therapy. But there's a tendency to see more delayed gross hematuria in anticoagulated patients. They can have to return to the hospital, some need hospitalization, some need even surgical revision. So these are always a tricky population of patients to treat. And most papers give little details about this anticoagulation management, and there seems to be higher incidence of high-grade clavient indo events after GreenLight in these very high-risk patients. We are awaiting the results of a French study to clarify more the role of GreenLight in anticoagulated patients. Also, retreatment rates are difficult to judge because the randomized clinical trials have include very little amount of prostate larger than 100. So it's difficult to know, but it looks as if PVP probably leaves more tissue, and then that potentially can impact reoperation rate. Regarding sexual function, the rate of retrograde ejaculation is relatively low, which is consistent with a technique that doesn't remove whole adenoma. There was no differences between open prostatectomy, TURP, and PVP in erectile function. However, some patients, especially those who had better scores in erectile index function, could have some deterioration after 2 years. The current standard is the 180 watt laser, and as I said, there hasn't been any technical improvement for the last 10 years, but there have been surgical technique improvements, like the description of the anatomic vaporization that has been studied in Italy, showing that it can remove more tissue. It allows to reduce the PSA further after the procedure. Also, GreenLight enucleation is possible, and ejaculation preserving PVP is another field of interest with this laser. Let's move on to diode lasers. Diode lasers are recommended with a weak strength by the guidelines as an alternative to TURP with the 980 diode laser with vaporization, and it can be used for enucleation as an alternative to TURP or bipolar enucleation. They are cheaper lasers to produce and to purchase. And diode includes different wavelengths. There are many wavelengths that can be produced with diodes, and that helps a little bit to confuse us a little bit more. The two randomized clinical trials with the 980 nanometer laser at 120 watts were compared to monopolar TURP, and they could see that at 1 or 6 months, the clinical parameters were the same, but at 12 and 24 months, TURP was better, and more patients needed reoperations after diode. There's three randomized clinical trials comparing diode laser enucleation with bipolar enucleation. And again, and this is a constant finding, when you do enucleation endoscopically, there's very little differences between different treatments. One randomized clinical trial compared the eraser laser with a wavelength of 1318 with bipolar TURP, and there was similar efficacy, but the hemostasis of this laser was much better than TURP. Also, another randomized clinical trial with 1470 nanometers, enucleation versus plasma kinetic resection, show no differences postoperatively, but better coagulation, bladder irrigation time, catheterization, and hospital stay with the laser. So there's confusion because initially in these studies with the 980 laser, there was a high reoperation rate and even persisting stress incontinence in up to 9% of patients. Whereas the latest diode laser papers doesn't seem to show this problem, but this means that there's probably diode lasers provide good hemostatic properties. The diode laser enucleation seems to be efficacious and safe when it's compared to TURP or bipolar enucleation, but we need more data to get to know these lasers a little bit better. What about Thulium? Well, there is a recommendation as well of the European Urological Association to offer Thulium as a resection technique, as an enucleation technique, but there is a mention that we need more studies with Thulium. There are three things you can do with Thulium. You can resect the tissue in a fashion similar to TURP. You can do, Thulium, as I said, cuts very well. So if you try to do an enucleation in 3 lobes using a classic technique, many times you're going to be able to detach 3 lobes, but not necessarily following the plane. You know, there being a continuous wave laser, there's no there's no explosive effect on the tip of the fiber that opens the plane, so you can get lost very easily. Some surgeons, and I have seen Thorsten Bach, for example, doing an excellent procedures with TUVEP, totally anatomical, but most surgeons probably leave some anomalous tissue behind. And then Thomas Hermann described the THULEP procedure, which is the Thulium laser enucleation, where he does a mechanical dissection of the anatomical plane, and he uses the laser as a supporting energy for cutting and coagulating. So when you look at TUVARP studies with long follow-up compared to monopolar TURP, bipolar TURP, and you see the results are pretty good, are comparable. The many prospective case studies with Thulium vapor enucleation, and they're also favorable. When you compare Thulium laser enucleation, anatomic enucleation with TURP, it is superior to TURP in safety, and it has a similar efficacy at 1 year follow-up. When you compare it, Thulium laser enucleation with bipolar enucleation, it seems that Thulium, and this is also a constant, I think lasers coagulate a little bit better than bipolar devices, so the quality of hemostasis is a little bit better as well. And when you compare Thulium laser enucleation with HOLEP, apparently there is no difference. So again, we hit the same stone. Regarding tolerability and safety, there's a high intraoperative safety in randomized clinical trials and case series, including those with large prostates, anticoagulants, or bleeding disorders. The complications are probably less with Thulium vapor resection when it's compared to TURP, and also in meta-analysis looking at these 2 techniques. So very nice, and you can see with the different techniques, the rates of postoperative strictures and the operation rate are quite low and very compatible with any endoscopic procedure. There is some impact on erection, but it seems to be temporary. Patients drop the quality of their erection at 3 months, but then slowly get better over time. And we cannot explain this very well. Regarding hemostasis, well, there are several randomized clinical trials comparing thulium enucleation versus TURP versus biPOLEP versus HOLEP that show that thulium has better hemostasis, but there's 2 randomized clinical trials comparing THULEP and HOLEP where there's no difference at 18 months of follow-up. And there have also been refinements in the surgical technique for Holmium laser anatomical enucleation, and I want to call your attention to this paper by Thomas Herman, where he reflects on how things have changed with maybe the same philosophy to protect urinary continence in patients and sophisticate a little bit the technique to make it even safer for patients. There's the new kid on the block, you know, the Thulium fiber laser has a wavelength of 1940, and it has been more extensively studied for stones, I think, than for BPH, but there are now some papers with looking retrospectively at their results with this laser when it's used for enucleation of the prostate. We will have to wait to compare it with other standard techniques to get to know more about this laser, but again, I think it lacks the explosive effect of the Holmium for enucleation. We have to see. We haven't used it in Europe yet, and we have to see how it behaves. Also, bipolar enucleation, I think it's a very affordable option, and most of the guys or our colleagues who are doing TURP and are defending TURP probably should get interested in learning to do BPOLEP, because it's a wonderful technique, and despite possibly there's a little bit more bleeding postoperatively than laser procedures, it's an excellent technique, and it avoids open surgery for many patients. I want to have a word on morcellation. Morcellation has changed. We all remember the live operations in congresses where morcellation took for ages. Now we can take out about 11 grams per minute, which means that when we do an enucleation, many times it takes about 35-40 minutes to do the enucleation phase and maybe 10 minutes to do the morcellation of an adenoma of 100 grams. So enucleation is no longer a 3-hour surgery. It's more often can be performed under 1 hour. For 60-gram prostate, sometimes it's 25 minutes. So with experience, you can really master these techniques. It's not so difficult. Many people who wanted to learn, I think everybody who wanted to learn ended up learning. You just have to do whatever it needs to learn. So in conclusion, I think Holmium has excellent results. It's the best studied technique. It treats concomitant stones, and there are very nice developments in technology and techniques. GreenLight PVP is excellent for high-risk patients. It also allows for a decent vaporization, and it allows the surgeon to evolve towards enucleation technique and hybrid techniques where the lateral lobes can be vaporized and the middle lobe can be enucleated. Thulium is a very solid laser. It allows for vaporesection with similar results to TURP, and also as a step towards THULEP and ultimately THULEP. Diodes are cheaper, but we need more evidence, and the thulium fiber we have to see. And for everybody who would like to get to learn to enucleate, and if they have a bipolar system, you can straight away start to learn. So now let's move on to other options, and this is the prostatic urethral lift. It's a true office procedure that can be done under sedation and local anesthesia with 0% risk of ejaculation. Of course, the improvements are inferior to TURP, and it's probably most indicated in patients who need to preserve ejaculation with prostates that are not too large and preferably without a middle lobe. This is how it works. I hope you can see the animation, at least frame by frame, but the cystoscope is introduced in the prostatic urethra, and there is the deployment of this suture that will compress the adenoma and will keep the channel open. In general, it's a 50% technique. It reduces IPSS by 50%, the Qmax improves 50%, and the quality of life score improves about 50%. Initially, it was evaluated versus sham in a multicenter study, and then they followed up the treated cohort even for 5 years. And you can see that the results are moderate but significant, and they could see that 13% of patients needed to be retreated over 5 years. So there's a trade-off. If you want to keep your ejaculation, maybe the improvement is not going to be as good as other cavitating techniques, but well, it's an option. These randomized clinical trials, the BPH6 study, compared TURP with the Urolift. And of course, the trick here was that they changed the way to evaluate a BPH procedure. Before, we would look at flows, post-void residual, etc. And here, other factors where this BPH6 criteria were included. And of course, when you look at erectile function, ejaculatory function, recovery after the operation, Urolift looks very good, better than TURP. Regarding tolerability, most symptoms are mild to moderate and resolved in 2 to 4 weeks. And the impact in erectile function, sexual function, is virtually none. So patients can keep on with their sexual activity without impairment while improving their urinary symptoms. With the intraprostatic injections, we know that Botox doesn't work. So you shouldn't be offering Botox in the prostate. There were several studies showing that there was modest clinical benefits, but not superior to placebo. And some systematic reviews and meta-analysis show that there's no benefit for medical practice, so it has been abandoned for the prostate. But there are 2 molecules that are promising. The PRX302 has confirmed some activity, and especially the NX1207 that is injected under local anesthesia in a few minutes. It doesn't need a catheter, and apparently it has some significant effect. So picture that, being in your office, sticking the needle under, I don't know, transrectal ultrasound control, and having the patient improve significantly without having to be operated. So maybe this is going to take us all out of business in the future. We have to wait for further studies. Regarding minimally invasive simple prostatectomy, this is a logical consequence. When we started doing laparoscopy and then robotic prostatectomy, the question arose, could I do an adenomectomy with laparoscopic and robotic? And the answer is yes, it can be done. The outcomes in this meta-analysis, including 27 studies with 700 plus patients, the results are quite good. It's a long operation, but there is probably less blood loss than the open operation, and patients can go home earlier. The catheter time is less, and there is no difference in the quality of the operation. So it's attractive for many people, and the complication rate is about 10%, mostly low grade. There has been a switch from laparoscopic to robotic. Robotic is now performed more often, and of course, in my opinion, it's a feasible thing to do. If one of the nice things is that the learning curve is very short, because if you can do a radical prostatectomy, what you need to learn to do a robotic prostatectomy is probably not so much. You already have the skills to perform the operation, and that's why it's attractive, especially in areas where robotic procedures are performed very often. This is an interesting study from Luzuardi. He compared laparoscopic adenomectomy versus razor laser, one of these diode lasers, enucleation of the prostate. And of course, he demonstrated that patients fared much better after the endoscopic enucleation. No need for abdominal wounds, no need for general anesthesia, better hemostasis, catheter out very fast. So, but of course, there are different options. Now we will discuss the iTIND. The iTIND is a device that can be implanted under light sedation with a cystoscope. It is positioned in the prostatic urethra, and it will expand over 5 to 7 days, and it will exert some incisions in the bladder neck. And it can be taken out in the clinic under local anesthesia with a special catheter after 5 or 7 days. Basically, it's going to perform a Mercedes star incision in the bladder neck, reshaping this bladder neck and opening it up. So it's a minimally invasive way of doing a bladder neck incision. There's this 3-year follow-up of this single-arm prospective study in 32 patients. And patients after 36 months experience a drop in IPSS of 12 points, 41% rise in Qmax, and a low rate of complications. And it's still under being studied with a multi-center clinical trial. And this is the AUA presentation of the abstract of an interim analysis, where you can see that there is an improvement in IPSS, quality of life, Qmax, PVR, and etc. with good tolerance. So another option in our armamentarium. Aquablation has entered the arena very fast and very strong, basically because they did very good studies to show its possibilities. It remains under investigation, but there's some recommendation from the European Association of Urology to use it as an alternative to TURP. The surgical principle, and this is a video provided by Dr. Enrique Rijo, who does these amazing animations. I hope you can see the animation. You put this device inside the prostatic urethra, against the anterior prostatic urethra, and a water jet with a lot of pressure will pulverize the adenoma. You can do it under transrectal ultrasound control, and you define very well the amount of tissue you want to remove, and a robotic arm is going to remove all this tissue without any energy. The question is, how do you do a hemostasis afterwards? And it has been done with a balloon or with diathermy after the procedure. The water study showed that it's as efficacious as TURP. The resection time itself is very short, it's just 4 minutes, and it is a cavitating technique, so it has a good clinical result with no significant difference in improvements in IPSS, quality of life, Qmax, and reduction of post-void residual urine. This is the efficacy 2 years after, and most patients could be followed up, and it holds up very well. Also in big prostates, there had been this Water 2 trial, and they studied 101 men with prostates from 80 to 150 milliliters, showing equally good results. This is the efficacy of 2 years, and you can see that there is big improvements in IPSS, quality of life, Qmax, residual volume, as expected by a cavitating technique. They didn't report urethral strictures, bladder neck contractures, or urinary incontinence. And it has been, let's say, demonstrated that it's non-inferior to TURP with lower rates of an ejaculation. And the only concern is how to do hemostasis in these patients. Initially, a traction device was used with a balloon against the bladder, but this caused pain. Patients had a little bit higher blood pressure because of the pain, bled, so there was transfusions. But those who do it very often, they're telling us it's getting better and better. After they do the ablation, they go in, they coagulate the bladder neck bleeders, and bleeding is much less, and they can get a very good result. So for me, aquablation, before I move on to Rezum, I think it's a very good option to TURP, and maybe without a lot of experience, you can do a very good cavitating technique, and it shows promise. Regarding Rezum, Rezum is a system that uses radio frequency power to create thermal energy in the form of water vapor. And this steam disperses through the tissue in the prostate, and it can be done in the office under sedation and local, and this is how it works. There's a needle, this reminds us of the tuna procedure, going in the tissue and dispersing this vapor that is going to heat up the cells and the tissue, and is going to kill the tissue, producing necrosis. And then after repeating the injection a number of times, depending on the prostatic size, and also in the middle lobe, the patient is treated. There's a multi-center randomized clinical trial with 197 men compared to sham, showing good improvement. This technique, when you cystoscope these patients, they have a cavity after some time. So really, it seems to be working. And at the AUA this year, the retreatment rate after this procedure is 15%, but only 4% need surgical retreatment. Some of the patients need drugs over time, and that's depicted in this graph. But many patients have a very good improvement of their Qmax and their IPSS, and it remains pretty stable over time. So also very interesting thing. One thing that is almost never discussed in meetings and papers and everything is that after you generate this necrosis, most patients will need postoperative catheterization. And the rule of thumb is 1 day of catheter per 10 grams of tissue, so maybe 3 to 7 days with a catheter after the procedure. One of the users, heavy users, told me patients hate you for a month and then they love you. So it's something to have to take into account. That Rezum seems to work well, seems to be a nice durable technique, but they have to undergo this initial discomfort. Regarding prostatic artery embolization, it's an interesting alternative also to induce necrosis in the prostate, and it's still under investigation, but it's accepted in multidisciplinary teams where decision is taken by urologists and radiologists. I remember operating a patient after a prostate embolization. The patient had a stone in the bladder, but the radiologist didn't care about that. He just treated the prostate. So it's important to have these multidisciplinary teams, and apparently patients with larger prostates might have more to gain. There are 3 prospective randomized clinical trials versus TURP, and apparently there are significant effects in both procedures, but TURP acquires better Qmax, post-void residual, IPSS, and quality of life improvement and prostate volume reduction. It is also faster, but of course, the embolization has less catheterization and less hospital stay. Regarding tolerability, there's a systematic review of comparative studies showing that the frequency of problems is higher with embolization, but there's another study with meta-analysis with 4 studies where there's no significant differences in postoperative complication rates. There's concerns about the amount of radiation that patients receive during embolization, and of course the possibility of targeting other organs and having complications related to embolization, but recent studies are reporting less incidents. I guess it's a nice option if you have a very good radiologist, if you have a very good connection with him, and if you select your patients very, very carefully for this procedure. There are a number of competing technologies coming up and being studied, and I'm going to go through them. They're quite interesting. This is a new device. This is a clear ring that it uses a very, let's say, imaginative mechanism to positioning a balloon inside the prostate, and then with a special cutting electrode, the mucosa is cut, and there is a ring implanted in the prostatic urethra submucosally, and you can put 1 or more, and it has been already studied in some patients, but we have to wait to see how the procedure fares. Also, the Zenflow is another implant with nitinol. It's removable, and apparently there are studies with 18-month follow-up. IPSS is dropping 6 points, and patients can experience urgency and dysuria, but there's still ongoing studies. The Butterfly is another competing device. It's a very simple design. It goes in the prostatic urethra, opening the anterior part of the prostatic urethra and improving micturition, also under study. There's also this water electrolysis system for the treatment of BPH, which is going to submit the tissue to acid and alkaline pH, and that will cause also tissue necrosis. And apparently the improvement is mainly symptomatic, not so much in terms of flow, but again, another minimally invasive option. And guess what? This is a balloon dilatation strategy. This balloon has been used for urethral strictures. It's coated with paclitaxel, similarly to what happens in the heart when they do a catheterization of the arteries to dilate. They use this drug that prevents further fibrosis, and it seems to produce an anterior commissurotomy, and it has very impressive initial result. As you can see, the Qmax goes from 11 to 22, and it remains quite high until 12 months. So we will have to wait for more studies to see if this strategy works. And also histothripsy is another option to damage prostatic tissue from the outside without entering the body. And there was a first patient treated at the University of Michigan, and there's still clinical trials going on. So finishing my talk, I think when we face a BPH patient, we have to consider a number of things. We have to consider his desire for a durable treatment, the risks he's taking now, or the risks he might need to take in the future if we do a treatment that doesn't solve the problem forever. The cost of the procedure now and the returning cost. Of course, when the surgeon is experienced, this improves the results. We have to consider the long-term effect on bladder function, the impact on sexual function, and how much industry is pushing us to use their devices and expanding indications. Maybe some device which is pretty good for a certain type of patient is not so good for other patients. And we have to be clever and think about the patients and the correct indications. Now we discuss the tailored approach, but of course, which kind of tailor do you want to be? Do you want to be a good tailor who solves the problem of the patient, who really, make a good fit for the patient, or a cheap, let's say, tailor who does a fix for the patient, but it's not so good? Also, are we like the dentists? When you go to the dentist, you do not hope for a definitive fix. You will be back on the chair again. So what is our role? Are we happy to do fixes and keep treating our patients once and again, or do we treat them once and for all and solve their problem? Well, this is something we have to discuss with them, but it's very important, I think, to be honest with them and make them participate in the decision. All the techniques we have discussed are interesting. They have an effect on the patient symptoms, and sometimes it's puzzling to see how a patient who has a flow of 13 is very happy because he had a flow of 7 before. And so we have to keep on learning. We have always used this classic graph discussing risk and benefit of these drugs, but unfortunately we're going to face a very, very tough worldwide economic crisis, and how is this going to affect us? It's quite difficult to know. I think we have to add another axis to the graph and consider the cost of the procedures. Probably national health systems are not going to cover certain procedures that provide a temporary fix for patients, and maybe ejaculation preservation will not be so important in the face of a huge economic crisis. We don't know how this is going to play out, but of course, a nice spot is the high benefit, low risk, and low cost. And I think there's a big role for HOLEP, and especially BiPOLEP, I think. And otherwise, we will keep on doing TURP, which is probably not the best option today. So take-home messages before we go to the questions. I think TURP is a good option, maybe still the current standard, but no longer the best option. I hope to have demonstrated that there are many options that are better than TURP in terms of safety and even efficacy. The phrase TURP is the gold standard should not stop you from learning new techniques and new stuff. Endoscopic enucleation of the prostate works well long-term with minimum morbidity, but it impairs ejaculation. The prostate urethral lift provides a very good sexual preservation with modest improvement and a 13% surgical treatment at 5 years. Aquablation is interesting. It's a little bit expensive, I think, compared to TURP, but it is a cavitative technique similar to a good TURP, and everyone can do it. Not everyone can do a good TURP. Rezum is also a cavitating outpatient technique, but patients have to undergo this hard, let's say, postoperative month after the procedure. And iTIND is probably a less invasive option to transurethral incision of a prostate. And now I thank you for your attention. We have had almost 400 people attending, and I'm going to try to read the questions. Let me just have a look and see if I can answer some of the questions that people are making. So in patients with diabetes and urinary retention, do you do urodynamics before HOLEP? Well, my answer is usually not. HOLEP is an amazing technique that removes the whole adenoma, and even if the urodynamic study shows a contractile bladder, I would do a HOLEP, because some patients can just sit down in the toilet, relax the pelvic floor, and urinate. So I don't think the urodynamic will add anything to these patients. You have to operate them and try, I think. What is your approach for post-HOLEP incontinence? How much time before they improve, especially if they have total incontinence? Does mobility of a patient affect that? Meaning if the patient is in a wheelchair or is wheelchair bound? Well, my approach for post-HOLEP incontinence is prevention of incontinence. I have to say I see very, very little incontinence after HOLEP using the en-bloc approach and the early apical liberation. Of course, we see patients who have urge incontinence after HOLEP. They probably are the patients who can tell you before the operation that they have urge incontinence. They have a very severe bladder hyperactivity with high pressure, and for 3 or 4 months they can have this urges to void and incontinence, but they tend to get better. I would say that probably more than 95% of these patients will improve over time, and if they don't, then we have to treat their bladder with Botox. But we don't do Kegel exercises preoperatively. We don't do Kegel exercises postoperatively. Nowadays, HOLEP doesn't need to produce a high rate of incontinence. If there is incontinence in a patient, I will reassure him that he will get better, and probably we would do pelvic floor rehabilitation. We use also drug treatment with what's the name of the drug? Now I forgot. But as I said, the most important is prevention. HOLEP is no longer a problem as it has been in the past, and the rates of incontinence are very, very low. After 1 month, it's probably 1%. How do you deal with high PSA before HOLEP? Well, this is an interesting question. When we have a patient with high PSA before HOLEP, we tend to do an MRI of the prostate. If there is a suspicious lesion, then we would do a targeted plus systematic biopsy. Or if there is, let's say, a high suspicion of prostate cancer, digital rectal examination is suspicious, or PSA is too high for the prostatic volume, we might do a biopsy before HOLEP. But when things are reasonable, many times, if the MRI is negative, we would proceed to do a HOLEP. But of course, we discuss the chances with the patient. Sometimes patients prefer to have a biopsy beforehand. Sometimes we treat a lot of very old patients where possible incidental diagnosis of cancer is not so important. So we have to adapt to the patient. The next question is, what optical device you use or recommend to guide morcellation in the bladder? A nephroscope, a laser cystoscope? Yes, you need a nephroscope to do morcellation because the morcellator blade is quite thick and it wouldn't fit inside the channel of any cystoscope. So we use a nephroscope. Is there a risk of foreign body infection in prostate urethral lift procedure? Well, I think there is maybe a risk. I don't think it's very relevant, and I don't think there are many cases of abscess formation or any other problems. There can be calcifications, and the Urolift can be a problem for a number of things. For example, it changes the MRI images, so it makes early detection of prostate cancer more difficult with MRI. And if you have to do an enucleation of the prostate of a TUR, you can find that taking out the metallic part of the lift device can be a problem, especially when you have to morcellate. And this is also the content of another question: how do you remove Urolift during TURP when the prostate enlarged? Well, you have to cut through the suture and take it out with the loop. Another attendee is asking, so long as I listen, I understand that TURP is still best choice for prostates from 30 to 80 milliliters. Do you agree? No, I don't agree. I think it is a good option, but it's not the best choice, as there are studies that have shown that the outcomes are better when you do enucleation of the prostate, anatomic procedures. Does selective arterial embolization work? And if so, how long after embolization? Well, it seems to work. And it seems to improve patients. And it takes a little while to the necrotic tissue in the prostate to settle down. So I think the main indication is the older patient, catheter ridden, who has a high risk for an operation. So I haven't got a lot of personal experience with this arterial embolization. We don't use it, and I have reoperated a number of patients submitted to embolization. So I'm not a big fan, but I think there's data out showing that it can be an option for these patients. Where does Fexapotit stand with FDA and EU approval? I am not aware of what is the situation. I think we need to see more studies and studies that compare Fexapotit to established treatments before this can happen. Does robotic adenomectomy for large adenoma, is it economically justifiable, especially compared to HOLEP or Thulium? Well, I think, in my opinion, it's very expensive and it's much cheaper to do HOLEP or Thulium enucleation. but many centers do not have, let's say, a laser or do not have the experience, and they do have the experience of the robotic procedures, and many times patients are willing to pay for it, or the insurance companies cover that. So that's why, but I think economically it shouldn't be justifiable. The cost is much higher than the cost of endoscopic enucleation of the prostate. Also, in a private one-day surgery clinic, what technique do you recommend? Well, if you want to do ambulatory procedures, I think you can do GreenLight very safely. There are many, let's say, protocols and centers that do day case surgery with GreenLight. There is a move now to do also HOLEP with daycare. It is feasible, especially I think the Moses technology will improve this because the quality of hemostasis is much better. And what clinics usually do is to send the patient home with a catheter and remove it 1 or 2 days later. Do you have some experience with Rezum technique regarding patients with permanently indwells urinary catheter? Well, this is an area of investigation now, and it seems to work well in certain cases. I personally believe that a patient who has had a retention of urine probably benefits more from an anatomic technique. Many times patients in retention have weak bladders, and they benefit from a, let's say, exhaustive technique that deobstructs them the maximum. But there's a paper out, I think, showing that Rezum can help in patients with catheters. I would like to answer a question, ask a question. Is there data regarding to infection, big holes after Rezum? What is the own idea of myself regarding the future for Rezum? Well, I run a practice where I get a lot of patients who come with very large glands, very big catheters. I don't see a lot of young patients who want to preserve ejaculation, and for the moment I haven't decided to do Rezum myself. So I don't understand this question very well, but I think it has a future. I think it's a simple procedure. It's a minimally invasive operation, and patients seem to have a nice improvement. So I think it has a future. The situation with VPH treatment resembles the situation with PCNL, where we have a standard size, but there are some smaller approaches which all have less efficiency, but we try to find other advantages, low blood loss, pain intensity, etc. With VPH, we have enucleation, but there are some other less effective techniques. However, we try to find their advantages in ejaculatory function, length of stay, etc. But what is the aim of surgery? To relieve the obstruction or to have less days in the hospital? In my opinion, all new minimally invasive options are moved by companies. They are not for patients' demands. Well, you have a point there. I think before you tell the patient, I'm going to operate you and you will lose ejaculation, and the patient would lower his head and accept what we said. But if you tell the patient, would you consider an option that preserves your ejaculation and maybe is not so effective as a definitive operation, would you consider having an operation later in your life or risking to have it later in your life? Then many patients are going to be happy with this approach. Sexuality for some people is a very important thing, and of course I think there is a role for these procedures, but of course there is also a lot of pressure from companies, and yeah, you have a point. I prefer to do definitive procedures, and it's very reassuring to see patients coming back after 10 years and still be happy. You know, this is very satisfactory. But of course, sometimes we see patients who say, I'm very happy with my micturition, but I miss my ejaculation. So I think, let's see. There is a doctor say here that costs in Latin America are to consider. Which technique do you think has the best balance for us? I think in those countries where cost, let's say, makes it very difficult to purchase a laser, for example. Although lasers today should be a standard for stones, you know, I think maybe for a little bit more you can get a high power laser for a relatively cheap low power laser allows you to do enucleation. And in the case that you cannot, let's say, have a laser and you have a resectoscope, then I think you should aim to learn bipolar. Because if you do bipolar, you're going to have extremely happy patients and very good results. And then your practice is going to grow, and then you will be able to buy a laser, which provides probably a little bit better better postoperative outcomes. Do you need to leave a catheter post-Rezum even if the patient had no catheter preoperatively? Well, this is what I was saying, that the initial studies report a very low rate of retention of urine, but if you look at many centers offering Rezum in the US, they all tell the patients, you're going to have a catheter for some days. So I think there is a discrepancy between published information and the real-life practice. So, and as I said, this rule of thumb that 1 day per 10 grams of prostate size. So I think most centers are using catheters after Rezum. In young males with lower urinary tract symptoms, if diagnosed as primary bladder neck obstruction, in video urodynamics, what would be the best option? Well, I think for a bladder neck obstruction in a young male with a small prostate, probably the best option is a bladder neck incision. Bladder neck incisions is a nice operation. We do it under sedation with Holmium laser, and the patient is discharged the next morning without a catheter. So I think that would be my choice. What are the rates of reoperations in aquablation? I think they're very low. But there are some, I think, in the initial studies. Aquablation is interesting. It doesn't feel like an operation in the sense that you have to put the catheter, let's say the probe inside the prostate, and then you plan the treatment, and then it's done. And then you go in, you take out some debris of tissue, you coagulate the bleeders, and then you put a catheter. But it is a truly cavitating technique. So I think the rates of reoperations in aquablation should be in the region of the rates of operation in TURP. Hello, Professor. Do you organize HOT or for HOLEP or BiPOLEP in your clinic? Well, in normal life, we would receive a lot of visitors and organize courses. We are always happy to receive visitors, but I think we have to wait until this COVID situation clears. So everybody is welcome to contact me if you want to come, if you want to learn, but for the moment it's quite tough because of the travel restrictions. What is the learning curve for HOLEP and your advice to learn and start HOLEP? Okay, so first, if you want to learn HOLEP, I think it's very, very, very important that you watch many procedures. You shouldn't be watching one or two and then try to do it, which is the normal tendency. You should really understand the anatomy because it's a different battlefield than what you're used to. If you have seen, let's say, 20, 30 procedures, then you're much better equipped to do it. I think in your first cases, you should have someone to help you, someone with experience, and then you can fly after that. It's very important to select small prostates, not impossible cases. Probably not too small because the plane is not very well developed in the smaller glands, but maybe choose patients between 60 and 80 grams. Also, if you choose these patients wisely, then you have trouble, you can always revert to TURP and try to have a learning curve that doesn't, I mean, the patients do not have to pay for the complications, do not have to suffer the complications. Also, I think it's very important when you're going to take this technique to your hospital it's very important to take someone who knows how to do it properly first and let him do the cases. So the anesthetists, the hospital, the nurses, they can see how good this procedure is. And then when you start and you take initially, I don't know, 2 hours to do the procedure, everybody understands that the procedure is very good, but you are learning, you know. If you start on your own, maybe you will find that the environment is going to be against you because it takes too long and things like this. Are there other options than open surgery, laser prostatectomy, and robotics in case prostates over 200 and 300 cc? Well, these very large glands have limited options. I think embolization could be one of the options that you could think about. Yeah, we tackle these prostates with laser. Of course, we tell the patients that they might need a second stage, or you know that there might be a need to do a cystotomy to remove the tissue. We discuss these possibilities. Most patients would prefer to have a second go if the case is very difficult. Let's say, imagine you do the enucleation, it takes a long time, and you start with modulation and it takes a long time. But I have to say these very, very large glands are difficult to do. They are doable, but they're difficult to do. Would you support the idea that in South America we have to support HOLEP as the safest time in terms of COVID? Yeah, I agree that HOLEP is a good option in times of COVID. This morning I had 3 cases, and they were mid-sized prostate, 60, 50, 70, something like this. And we had 2 operating rooms, and we could do it in less than 2 hours. So it's once you learn to do HOLEP, it's an amazing technique. And these patients go to the room. There's no much bleeding. We leave irrigation that we take out after when it's not needed, and the catheter is taken out the next morning. We have a nice catheter removal protocol. You know, we wash the bladder for clots. We wash the prostatic fossa. We take down the balloon. We wash the prostatic fossa. Then we fill the bladder with 200 milliliters before we remove the catheter, and then patients tend to void spontaneously. And then we give the patient Lasix furosemide for 20 milligrams, and they usually can go home after 2 or 3 hours because they have already peed 3 times. Is erectile function affected differently by these techniques? Well, yeah, in general, BPH surgery has a moderate minimal impact in erectile function, I would say. And yeah, duloxetine is the answer, yes. Before I didn't remember the name of the drug that I use for incontinence, and I have to say that thank you, one urologist who reminded me of this. So I hope you have enjoyed the webinar, and I hope everybody keeps healthy and safe in your own countries. Take very good care of yourselves and your families, and you always have a friend in Madrid. If you would need to learn anytime when we can travel again, you will be welcome to come. Thank you very much for your attention, and I hope that my opinion was coherent for you, and you liked the presentation. Thank you very much.